Start easy, right? We can start. Yes. So let's go into it. Welcome to the second edition of our vaccine series. Is NSSF. This series is being co-hosted with Vaccine Confidence today, and we are excited. We'll be speaking about data and the importance of data, the relevance of data in vaccine uptake in Nigeria. We would be taking questions as the speakers speak and as the panel session go on. So feel free to type in your questions in the Q&A session. If you have any or comments in the chat box, if you have any comments you want to make. Welcome again, and over to you, Izzy. Izzy, are you able to unmute yourself? You can't. Okay. Can you please unmute Izzy? Thank you.
There we go. It's working now. So hopefully everyone can hear me. Thank you so much, Dr. Fajero, and hello, everybody. It's fantastic to be here today moderating what I'm sure is going to be an incredibly interesting discussion. I just wanted to spend a few minutes outlining what inspired this webinar partnership between the Vaccine Conference Project, which I'm here representing today, the Vaccine Data Collab, who we've got representatives on the call from, who are going to be taking part in the speaker session and the panelist session as well, and of course the Nigeria Solidarity Support Fund, who are our hosts today. Collecting and analysing immunisation data forms the core part of our work at the Vaccine Confidence Project. We aim to map and monitor attitudes to vaccination at a global scale, with a view to understanding the roots of concerns around vaccines, trends in vaccine attitudes over time, and how demand-side factors like confidence interact with supply-side issues to create potential programme disruptions. Generating this data and risk analysis at the national level is, of course, an important piece of the vaccine uptake puzzle, but it's not the whole picture. And the usefulness of data in informing vaccine planning and delivery is influenced by lots of other factors: how localised data is, how widely available and easily accessible data is, and how well equipped health data officers are to interpret it, to name but a few. That's why for the past year, we've been working with the Vaccine Data Collab to map these challenges and explore how immunisation data can be better used to accelerate vaccine uptake via research design and broader intervention strategies. The Nigeria Solidarity Support Fund have been a key partner for us both in this work, and we want to express our sincere thanks to the team for inviting us to share some of the findings through this platform today. In a moment, I'm going to be handing over to one of our esteemed panelists, Eduardo Solades, who is the Chief of Health in the UNICEF Nigeria Country Office, to provide some opening words of wisdom for us. Eduardo is a medical doctor and a public health specialist with more than 17 years of experience in international humanitarian development settings. Eduardo joined UNICEF from UNFPA, where he was a deputy representative in Mozambique. But just one final note from me before I pass the mic, which is to let everybody know that at the end of the webinar, a questionnaire will be popping up on your screens. We'd be super grateful if you could take a few moments to review this and fill this out for us. Over to you, Eduardo.
Okay, thank you. Sorry, I was unmuting myself. Thank you very much, Izzy, and thank you very much, Dr. Fajero. I would like to thank the Nigeria Solidarity Support Fund for inviting UNICEF, that is the UN agency that leads in immunization, to this very important seminar. And I'm especially happy because of my background. Before becoming the Chief of Health here in Nigeria, I used to be a health data practitioner. So I'm especially happy to be here today with all of you. I would like to set a little bit the context for vaccination in Nigeria and data. I would like to talk a little bit about two successes that I think Nigeria had over the last few years, two challenges and two opportunities that we have. I hope that this will help to the audience and to the panelists to set a little bit the scene and the debate. Two successes. One, if you're aware of the last report published by UNICEF in vaccination trends, Nigeria was one of the few countries in Africa where vaccination coverage improved during COVID-19 pandemic. This doesn't mean that everything was good, but it was one of the few countries that didn't go down right? That it still was able to improve immunization coverage during COVID-19. So that's quite a remarkable achievement for Nigeria. As well as, you know, the number of people reached with COVID-19 vaccination was quite astonishing. And more than 70 million people have been vaccinated, adults. The other success that I think all of us were aware is like 3 years ago, Nigeria was declared polio-free. This was a huge achievement when in August 2020, this happened. Still, as you know, Nigeria is facing still polio variants, but it proves that everything is impossible until it's done. And I think Nigeria showed that in vaccination things can be done. However, we're facing as well significant challenges. And I would like to highlight two challenges. The first one, in our opinion, is inequities. When we are looking to the last mixed data from 2021 on vaccination coverage, we are seeing huge inequities. In places like Sokoto, in the northwest of the country, Penta-3 coverage is 11% versus a national coverage of about 57%. And other states, especially in the southwest and southeast, with Penta-3 coverage over 85%. So inequities for us is one of the main challenges that Nigeria is facing. Inequities both between states, but as well within states with different LGAs. The second challenge that for us is the weak health systems, especially primary health care. The lack of enough nurses, midwives, community health workers, lack of infrastructure, etc. That this results in a very weak health system that is unable to really reach the most vulnerable children. And finally, which are the opportunities? So we believe that there are many opportunities, but I would like to highlight two. And one, maybe it's a paradox, but I would like to highlight that the current outbreaks that Nigeria is facing, for example, the diphtheria outbreak that is happening as we speak in 4 states, in Kaduna, in Kano, in Maiduguri, etc. It's an opportunity. Government is quite serious on trying to avert these outbreaks. So if we do the right analytics and we are able to do reactive campaigns, it's a way to accelerate vaccination. So we think that paradoxically, outbreaks can be an opportunity. And the other one is the use of data. And maybe this will come during the discussion. But with the current tools about geomapping, about accountability of health workers, etc., we believe that as much granular we are, much more successful we'll be in improving vaccination and reducing inequalities. And I'm sure that we'll have the opportunity to share some experiences during the seminar today. So Isi, that's it from my side. I'm really looking forward to the discussions and to hear from the panelists and to the people in the room. Thank you.
Sorry, everybody, just took a while to unmute again. Thank you so much, Eduardo, for sharing those valuable insights with our audience. Now for the part you've all been waiting for, which is the handover to our speakers and then to our panelists for the Q&A session. Including Eduardo, of course, we have an extremely esteemed set of experts with us today, and we are going to kick off with a short presentation from 2 of the leading female voices in global health. We'll first hear from Dr. Chizoba Wanodi, who will be sharing success stories on the use of data to improve immunization programs, with a focus on the importance of data quality. Dr. Chizoba is an associate scientist at the Johns Hopkins Bloomberg School of Public Health, with nearly 3 decades of experience as a public health physician. A recognized leader in the immunization field, Dr. Wanodi currently serves as the Director of Immunization for the USAID-funded Momentum Country and Global Leadership Project. Our second and final speaker will be Jadida from the Vaccine Data Collab. Jadida will be presenting insights from a data simulation exercise that the Vaccine Confidence Project and the Vaccine Data Collab jointly conducted in partnership with Datafy. We'll be looking at insights on locally led approaches to using data for vaccine decision-making as well, and they'll be drawn from the Vaccine Data Collab's portfolio of Nigerian grantees. We'll then move on to the Q&A session, where we'll be extremely pleased to welcome one of the Vaccine Data Collab's grantees as well, Chisholm Obi-Jeff. Chisholm is a global health researcher and implementation scientist with over 10 years of expertise in designing, implementing, and evaluating innovative and culturally acceptable primary healthcare interventions to improve the uptake and delivery of health service in resource-constrained settings. And joining Chisholm on the panel is the Nigeria Solidarity Support Fund's very own Dr. Vijero, who everyone's already met today. Dr. Vijero, as she said, is the general manager of the fund and a qualified medical doctor, as well as an accomplished executive of over 10 years of experience in programme management. With a proven track record in designing and implementing multi-donor projects from inception to completion, she's ideally placed to oversee the focus on a vaccination programme for Nigerians, driven by her passion for healthcare delivery. And last, but certainly not least, we will be hearing from Dr. Ismail Abdul Salam, who is the Director of Epidemiology at the Lagos State Ministry of Health. So without further ado, I will hand the virtual mic over to Dr. Chizoba to kick us off. But just one final note from me before I do, to say that we really want to invite audience participation in this session today. So if questions come to mind while you're listening to Dr. Chizoba speak, then please do post them in the chat and I will make sure they're addressed when we come to the panel segment of the webinar. Dr. Chizoba, over to you.
Thanks so much for that kind introduction. I am going to share my screen and start the presentation. I hope everybody can see it. Right? Okay. All right. So let me start from the beginning. Again, thanks so much to the presenters for this opportunity to. Can you still see my screen?
Yes, we can see your screen.
Is it in full presentation mode?
No, not yet. So if you could just put that into full presentation.
Okay. Is it back in full presentation mode?
Yes, it is.
Okay, great. Thank you. All right, so today I've been asked to talk about how we can use data to improve immunization coverage. And what I try to do with the task is to really focus on the demand side. I know that this is a vaccine confidence driven program, but without the supply, there will be no vaccination. Without the service delivery, there will be no uptake. So I'm going to really focus on the supply side. I'm going to start first with looking at trends of immunization coverage in Nigeria, just using one key indicator, the Penta-3. I know we're talking a lot about zero dose and equity, but Penta-3 still remains one of the core indicators to look at the strength of an immunization program. And then begin to now talk about the data itself, why we need immunization data, and what are the different sources of immunization data. And then I'll share some success stories on how data can be used both to move the needle on funding through advocacy, and then also to elevate the importance of immunization so everything can follow. Then we're also going to look at a specific example of how data was used in Nigeria to improve RI coverage, which is really quite remarkable. So why do we need immunization data? First of all, we need data to make evidence-based decision. And I think that is pretty self-evident, right? If we want to make decisions around how much vaccines to procure, how much funding to provide, we definitely need good data about the target population and coverage rates. We also need to assess the program performance. This we do by looking at coverage rates. We look at utilization of immunization inputs like vaccines, syringes, and all. And if we don't have good data, we could be misleading ourselves in terms of thinking we're doing better than we are. And I'm going to show you some data in subsequent slides to illustrate that point. Dr. Eduardo talked about outbreaks. We are now battling diphtheria outbreak. We need good data to understand how well the program is doing so that we will know when there are immunity gaps. So this outbreak of diphtheria is certainly happening because we have immunity gaps. Some kids have not gotten the vaccines that they require. And so the immunity wall within the community is broken, and then we have outbreaks. So we need good surveillance data to be able to pick them up on time and then mount an effective outbreak response. Again, we need good data for vaccine equity, to ensure equity. Equity is a big word now, is commonly used. If you think about IA 2030, one of their principles is equity, ensuring that no child is left behind. But how can you know if any child is left behind if you don't have good data? And we do have some challenges with admin data that, especially when the admin data tells us that we have 150 or 120% coverage. That essentially means that, first of all, the data is bad, and then secondly is implying that we've covered all children when indeed we know we have not. So good data will help us ensure that we are actually identifying those communities that are left behind, and then we are reaching them with the appropriate services. We need data to assure quality and assure safety. So that's around monitoring the adverse events following vaccination, if there are any. We need data for resource mobilization, planning and allocation. We need data to track progress towards our global goals, our country goals, our state goals, our local government goals. And some of this data can be organized and visualized in dashboards, and those can actually drive program performance, and it can drive advocacy, funding, and political will. Of course, we need data to address research and innovation, to see to what extent new approaches and new strategies are working. So that data on coverage, data on reach is really important. Now, here is the most recent WUNIC estimates. These were released last week or 2 weeks ago. WUNIC is data that is compiled by WHO and UNICEF. They triangulate data from different sources, and then they provide these national estimates for all countries in the world. And this data is for Nigeria. It's looking at the DTP3 coverage. So in Nigeria, we have the vaccine called the pentavalent vaccine. So what we see here is that, so for the most recent year they have is 2022, okay? So what we see here is that only 60% of Nigerian children aged 12 to 23 months old have received 3 doses of the Penta-3 vaccine. So it means that a little less than half of the kids are not getting the vaccines they need. And this, the solid line here is the WHO WUNIC estimates. But what is more interesting is that there is a variety of data sources for immunization. So if you look at the star here, the stars here, the stars are tracking the admin data. So admin data is data that's routinely collected in the health facilities, that the facility managers, the LGA managers, state managers, that's what they have available on a month-to-month basis to assess their immunization performance. And you can see here that the admin data is consistently higher than the WUNIC data. So WUNIC is a triangulation. They use survey data, which are the blue bars. They use survey data to estimate what the best number is for a country. So what the takeaway message from this slide is that, number one, we are not reaching about 40% of the children in Nigeria with 3 doses of the pentavalent vaccine. Number two, our administrative data is giving us a false picture, presumably a false picture. So that makes it difficult for program managers and providers to actually identify where they should be placing their focus. It may lead to complacency. It may lead to the perception that we are doing well when we're not. Okay. So now we move on to the next slide, which shows us which shows us some kind of a comparison between the different sources. Now, there are many reasons why the admin data could give us a false picture. And it is, for now, it is expected that the surveys, the household surveys, are the gold standard, okay? Even though they are considered gold standard, there are still some, challenges with the survey data. So first of all, from the slide here, you can see some of the advantages of household surveys. Because of the way the data is collected, we have more quality control. And then when we have an estimate for coverage, we can have error bounds around it. So if you say 50% coverage, you could say plus or minus 5% coverage. So you have more of the uncertainty measured. And then when you think about the advantages of the routine data, number one is measured every month. So it's available for use for program management. Number two, it is estimated at the lowest level, unlike the survey data, which you can only get survey estimates up to the state level. But then the LGA people need to know how they're performing. The facilities need to know how they're performing. So the only data they have is, or one of the data sources they have is the routine data. And then, of course, it's collected at no additional cost beyond the program cost. For you to do a survey, it's cost millions of dollars for surveys to be mounted across the country. So these are some of the advantages of the routine data. But the disadvantage of routine data is that it is sometimes there's incomplete collection. Some numbers are inflated. There are issues with denominators. So if the denominator is incorrect, then the coverage rates will be incorrect. And then, of course, is aggregated at the monthly level. So we actually don't know for an individual child whether or not they are fully vaccinated. So the available data we have some challenges. And here you can see, this is an old analysis we did for one of our projects, where we looked at, for each state, we looked at what their admin data was saying and what their coverage data was saying. And then we plotted it in a, what we call a scatter plot. And what you can see here is that this line, this diagonal line, is the line that shows there is an agreement between admin data and the corresponding survey data. But what you can see in this slide is that the majority of the states are above this diagonal line. It means that for most of the states, their admin data is much higher than their survey data. Look at Zamfara State. In the 2014 admin data, Zamfara State was recording a coverage rate of a Penta-3 coverage rate of 140% coverage, right? And then when you look at the corresponding survey data from the SMART survey, it was 5 or 6%. So that disparity is huge. Now, when you look at this another way, right? So we looked at it another way. What we did was to look at the difference between the admin data and the survey data, and then we plotted it on the map, and a pattern clearly emerges. So the states that are colored in red, those are states where the difference between the admin and the survey data was more than 60%. So the admin data was 60% higher than the survey data. Then those in green are the states where you have less than 20% discrepancy between admin and survey. And then those in yellow are those states where you have less than between 21 to 60%. So the story here is that for the most part, many of the states in northern Nigeria have huge discrepancy between the admin data and the survey data, meaning that is either they are overinflating the number of children they are vaccinating, or their denominator data is so off mark that even if they report their numerator data accurately, when you calculate the coverage, you're still going to get huge inaccuracies in their data. But there's no single way to know whether it's an inflation or a problem with the denominator data. So what NPHCDA then did was to look at additional ways to improve the availability of data, more real time, and then also of good quality, of better quality. So here I put some additional data sources that can provide information for program monitoring. So we have registries. So for registries, the data is collected at an individual level. So a kid comes in to be vaccinated, they take their name, they take their address, and then they also record the individual vaccines that that kid had received, and that can be aggregated. Then, but we do have that in Nigeria, but those are paper-based registries. The only way you can use it for efficient monitoring and action is if those registries are made electronic. And with the advent of COVID, NPHCDA developed what we call the EMID system, and there is potential that this EMID system can be translated into routine immunization registries. So those are some of the opportunities down the pike. Now, what NPHCDA then did was they now started doing what is called lot quality assurance sampling or surveys. So these are surveys that are conducted at smaller geographic areas. Recall, I told you that the DHS surveys only gives you estimates at the state level, but you still need to know what's happening at the LGA level. So with the lot quality assurance survey, we now get data around performance at the local government level. And we also get the data more frequently. So it's done quarterly rather than surveys that are done every 4 or 5 years. So with the LQS, you now have visibility into how the programs are performing at a lower level and with data coming at more frequency level. NPHCD also did another thing. They started SMS reporting. So SMS reporting is really use vaccinators or facility managers using their cell phones to text to a server the number of children that they have vaccinated for the different antigens, whether it's for BCG or for Penta or for PCV. They use a structured code protocol to simply text that message, and then that's aggregated. And that SMS reporting comes in pretty much live. It's real time. And then it's reviewed at the national level, at the state level. So through SMS reporting, they are circumventing some of the challenges with the routine data. Now, where are some of the success stories? I'm going to start from the top, right? Looking at some of the ways data and data visualizations and dashboards can be used to move the needle either on advocacy, financing, or just, attention and accountability on immunization. So on the left here, you have what we call the IA 2030 dashboard. I have put here a link to the YouTube video that shows how it's done. So my team at IVAC, under the Momentum Country and Global Leadership Project, actually led the development of this work. We, alongside, in partnership with WHO, UNICEF, CDC played a very strong role, especially from the technical aspect. And this dashboard is now being transitioned to WHO for use in the global monitoring of IA 2030 goals. On the right here, I show you an ALMA scorecard. So this is a scorecard that's used by the heads of states in African heads of states to look at progress on malaria. And the way this is used is that when these heads of states come for a meeting, this scorecard is displayed. And then all the heads of states will be wondering whether their country is red or green. And that puts peer pressure, that puts some kind of attention to the performance. And from the experiences using this ALMA scorecard, it's really been effective in driving political will, because when heads of states go to these meetings and they see that they are red all over, they come back and they summon their Minister of Health and say, why are we red? I don't want to see us red again. And then you see action follow from there. So that's an example from the global level. Now, in terms of Nigeria, there are some examples as well. So on the left, I've put here the summary of the COVID vaccination coverage in the different states. So NPHCDA started producing this when the COVID vaccination was initiated, and they were doing it state by state, and they used it in a clever way really to drive that peer pressure. So they will put it on their Twitter page, and then they will ask they will ask the public, find your state. What position is your state? And then people will be commenting on it and say, oh, why is my state the last number? Why is my state number 10? Why is my state number 36? So this is one way. And then also this is used when the executive director goes to have meetings at the governor's forum to show the states how they are performing. And this has really been one of the things that drive political will for COVID vaccination. So that's at the national level. And then finally, at the health facility level, this is a way that health workers can visualize the trends in Penta-3 coverage, vaccination coverage. So they, based on the calculations and the micro plans they've done, they expect to vaccinate cumulatively a certain number of children or a certain proportion of children. And if they're doing well and they're plotting this graph, the trend line should be on this red line. Now, if they plot it and they are below the trend line, they know they're not doing well, and they need to then look inwards and figure out why they are not doing well. So there are a variety of tools that can be used at multiple levels to look at performance. Now, what about, is there any evidence of impact of use of data for monitoring and for performance management? I would say yes, there is a big evidence of impact. Now, this slide is from a study that we did in Kebbi State, where we looked at improving immunization coverage using SMS reminders. And we then used the LQAS data that was collected by NPHCDA over time to compare our intervention and our control LGAs. But what was interesting when we looked at this data was that in both intervention and control LGAs, you can see that the coverage of the, or rather the proportion of children who are appropriately vaccinated for age was going up consistently from 2018. And it's around 2018 that NPHCDA started implementing the LQS, which they call Papa LQS. So from implementing the LQS, the LGAs were now finally able to know where they were in terms of coverage. And with that knowledge and with support and with using the data to drive action to prioritize where they need to pay attention to, you see that coverage started increasing in both intervention and control LGAs in Kebbi State. So coverage had increased way beyond up to 85% when we did our intervention. So our intervention was in 2019. That's when we did the intervention. And then this was after our intervention. So the story here is that the Papa LQS, the onset of the LQS intervention in Kebbi State, as well as other states where it was being done, shows a remarkable improvement in coverage of vaccination amongst children. And that could be attributed to the LGAs finally seeing what their performance is and then taking appropriate action to address gaps in immunization. So I believe this is the last slide I have. I'm happy to take questions during the panel session. Thank you very much.
Thank you so much, Dr. Chizoba. I personally find case studies of exemplars a hugely helpful source of inspiration, and your presentation really underlined the importance of sharing that knowledge and best practice as we think through ways to effectively tackle these global health challenges that we're discussing today. Audience, thank you for questions posted so far. They're going to be an extremely rich starting point for our panel discussion, so please do keep them coming throughout the next presentation, which is going to be from Jadida from the Vaccine Data Collab. Jadida, over to you to discuss the insights from the simulation exercise scenario that was performed in Cross River State earlier this year.
Thank you, Izzy, for that introduction. So my name is Jadida Owino, and I work with the DT Global. So let me just try to share my screen. Can everyone see my screen? Easy?
We can see your screen. If you could just make it full screen, please.
Okay. Is it okay?
Yes, we can see your screen. Thank you.
Okay. Thank you very much. So my presentation today is on the simulation that we carried out on 5th of June in Cross River State. So the simulation was how to use hyperlocal data to make decisions around vaccine planning, and also to make sure that we have a targeted vaccine decision moving forward. So the simulation was partnered with Vaccine Data Collab, DataFi, and also Vaccine Confidence. It was a one-day event. So why did we do the simulation? So one of the objectives of doing simulation was to test how data is used for making decisions, and also see the vaccine distribution planning, and also to understand what is missing and what are the actionable points moving forward. So we had some expectations that we expected from the audience, and especially the participants. So we had 36 participants, 18 LIOs and 18 CCOs. So CCOs are the cold chain officers, and LIOs are logistic officers, drawn from the 18 LGS we have in Cross River State. So the first expectation was for the participants to understand how data can be used to inform decision making for vaccine delivery and uptake. And the second one was for the participant to identify areas where additional data will be helpful in making more informed decisions. And the last one was for them to try to understand how the data producers, and these are the data entry people, can be connected or work together with the users of the data to make decisions and planning for the vaccine. So the core elements of the approach was we first look at a scenario where there's this highly contagious virus strain that emerged in Cross River, and the resulting is increasing hospitalization and appear to be primarily affecting individuals who are older or rather already vulnerable. So the World Health Organization has authorized the emergency use of the COVID vaccine and there is some reporting in terms of misinformation in the community, and people are angry, and there is also some level of hesitancy because of the use of the vaccine. So the day was divided into two. We had two phases. So we had the first phase was the supply, and then the second phase was the demand. On the supply side, we were looking where are the vaccine, how many are there, and where are they being distributed, especially. And also on the demand side, we were looking at who want to be vaccinated and who doesn't. And then this sum up into a microplan template that we used to determine how many immunization are needed and what staff is required, what are some of the resources that are also required, and how much will it cost. And then we look at the coverage in terms of looking in a period of 1 month, and that was in June. So at the end of the day, we had the government official from the state NPHCDA, and also we have the immunization director, and also the members from DataFi and Vaccine Data Collab had the opportunity to vote and to determine the winning team. So we had what scoring matrix to just make sure that the template that is going to come out is grounded on the data that we were using. So it's evidence-based, and it's also something that is achievable, it's realistic, and demonstrates some level of creativity and has been developed through effective teamwork. So another thing, we had a participant role. So this was something out of their normal roles, their day-to-day roles. So we had 4 roles. We had the data analyst, we had the public health and logistic officers, and also community leaders. So the team, out of the 36, we had 4 teams, all made up of 9 people. So on the supply side, we are looking at the vaccine stockpiles and the supply chain, cold management, and others. So some of the questions that form part of the supply phase was how many vaccines are there, what types are there, and where are they in terms of the distribution, and what vaccines are available, which primary health clinics. So we are looking at also the distribution of health facilities and how the vaccines are also being distributed in these health facilities. And also they got a chance to calculate the vaccine wastages. On the demand questions, we were looking at how can we get the most vulnerable and vaccine hesitant citizens to be vaccinated, and who are the most vulnerable in the community. So the microplan template was covering the percentage coverage of within 1 month, and that was June, the number of doses to be administered, the wastage, the resources, and others. So this is a photo of the event. So what did we learn? So when come to what we learned, we look at what worked and what didn't work. So one thing that worked so well was the data that was used on the supply side. The reason being the data was granular and it was able to speak directly to the participants. The participants were familiar with the data, and therefore it made the whole process of answering the question on the supply side to be a little bit easier than the demand side, as we are going to be looking at that. Also, there was a provision of airtime incentive. So this one worked well because it brought the part of competitiveness within the teams, and also just made them, motivated them to be engaging and talking and just making sure that they also ask questions because everyone else wanted to win. Also the team size and the selection of the team leaders. So the team size was not so big and was not so small that it allows everyone to just be part of the program, to be part and also just participate well. And also it gave them opportunity to choose their own leader that they felt very comfortable with. Another thing was the the microplan template, the way it was structured, it was straightforward. And it actually speak well with the participant because some of them were already aware of how the microplan looked like. The last part was the strong practical takeaways. So this was, as a team, we also created some maps for the event. And this map was showing the spatial distribution of the health facilities within the LGA level. And it was, most of the participants were able to actually relate to it and even identify that there are few missing health facilities who are coming up and were not captured in the map. And they were fascinated because they were able to see that being represented. Sorry. So the microplan template was covering the coverage in 1 month, the number of doses to be administered, the wastage, and the resources. So what works less? On the demand side, the data that was used on that event did not speak well to the participants. The reason being, we use national data that was showing hesitancy in terms of the states and not up to the LGA level, and it was not so granular for the participant to be familiar with it and to relate with it. Also, time constraint, and I think this is most something that affects most of the programs. We didn't have enough time. By the time we were the end of the program, some of the participants have not yet complete some of the questions. And also there was also some level of technological gaps among the participants. So we used laptops. So every team had a laptops to use for the presentation, and also to just look at some of the dashboards that we use for the demand side. And we realized some of the participants were not so much familiar or comfortable using some of the laptops and even interpreting the dashboards that we provided. What will we be doing next differently? So first, we will make sure that on the demand side, we have data that is granular, the data that can be able to speak to the participants and they can be able to relate with well, and also to just make sure there is some level of quality in terms of the data being so granular for them to also understand more, and also just do a prior orientation before the simulation day. And the reason being, we realized most of the participants did not stick to the roles that we came up with. And I think next time it will be better if we do the orientation a day prior and then the following day do the simulation, so they get to understand and also just get a preview of how the data look like and how to just interpret some of the dashboards or create a one dashboard, a one visualization. Also, another thing that we'll do differently is involving a wider audience and the wider stakeholders to be involved in the simulation, because also we realize we also need other people's input, especially an organization like UNICEF. So what next for the simulation? So we are working together with DataFi, and we are also welcoming other partners to come on board to also just do another simulation apart from this initial pilot that we did, and to be able to incorporate some of the learnings that we have brought forward from our pilot, and to leverage on the relevant existing subnational data that is also under our custody. So the process of designing a series moving forward, first, we are going to be looking at understanding the problem space, identify some of the states that has vaccine uptake gaps, and based on the data and also consultation with the right people. And then second one, how can we use the simulations session to respond to the challenges and making data more actionable for decision making. And this is by building on the learnings from the pilots and understanding the country co-design training sessions. And then the third one is how do we test things in practice? Identifying relevant data sets. This is very important because it came out when we come for the demand side. And also adapting the scenario to identify the gaps that are there and finding a decision maker to test this beforehand. And then the last part is to how do we know what's working? So this is how do we know what is working is by capturing some of the learnings, impacts, and optimizing this tentatively, and then creating some framework to test the efficacy of the simulation. So how does the simulation that we did fit into the broader set of intervention that also Vaccine Data Collab is actually supporting? So we have 3 interventions that is in Nigeria right now and is ongoing. So we have a case on data policy and data governance around immunization and routine immunization and vaccine. We have tools that are being built based on data-driven decision making and also to just help in terms of bringing different platforms together. And lastly, on capacity building. So that marks the end of my presentation. Thank you.
Thank you so much, Jadida, for that really insightful presentation. I think you outlined the challenges and the opportunities that we faced and encountered during the process of running the exercise really, really well. So thank you for that. In the interest of time, I want to move straight into the panel session now. And I'm going to kick off with an initial round of questions before moving on to some of the questions from the chat. But please do keep those coming so that we can come to them later in the panel discussion. Firstly, I'd like to come to Chisholm with a question as someone that we haven't heard from yet. So Chisholm, your project with the Vaccine Data Collab is exploring ways to incorporate adult learning principles into immunization training as a strategy for improving data and training capacity building. Can you tell us a bit more about the inspiration behind this and your approach to this work?
Thank you so much, Izzy, and thank you so much to the Nigeria Solidarity Support Fund for the opportunity. So we at Brooks Insights, the inspiration behind our project with Vaccine Data Collab actually stems from, the recognition that there are competency gaps among program managers and healthcare workers when it has to do with using data for action. In fact, specifically designing targeted interventions. So at NPA-CDA, the government through NERIC, one of the things they do is to build capacity of program managers to, improve service delivery. But one thing about that training delivery approach that they're using, that's a traditional model they use, which is called the TOT, that's a trainers model. There are still some gaps with that. There are concerns about how this training is being delivered, the competency of those delivering these services. But most importantly is that the training does not meet the different learning needs of adults. As adults, unlike children, we really learn when we are actively involved in the learning process and, through various degrees of interactive sessions. So be it case studies, group sections, group work, and all of those things. So, and again, we learn when we are able to apply our knowledge into real life situations. So what we are doing with our project is that we incorporated adult learning principles, into training healthcare workers and program managers on how best they can actually use data to identify and address immunization challenges. and most especially design tailored interventions. Thankfully, WHO did come up with the WHO TIP guidelines. So the WHO HCD, Human-Centered Design Tailoring for Immunization Program Guide. So which we actually did adapt in our situation was that we the tools, the template, understand this data and use it for action. So for example, in the diagnosis phase of the HCD, we introduced these program managers to what we call the BESD framework. So that's the behavioral and social drivers framework. So what this tool does is that it helps you really understand what people are thinking and feeling about immunization, right? What are the social processes that drive immunization for them? What motivates them to go for vaccination? What are the practical challenges they do have when it has to do with vaccination? So we train these program managers on how to use those tools and the key questions to ask from those tools. And then on the design phase, having diagnosed the problem, how to design the intervention following those findings from the tools. And for that, we did introduce them to a lot of tools. For example, how to map those barriers, right, on the journey to immunization framework. So how to map those barriers, how to prioritize those barriers, and then come up with strategies. And this is what we introduced the good enough principles. Now, good enough principles does not mean that they are second to none, right? They are just very simple solutions that put communities first, feasible and culturally appropriate and low cost, because oftentimes what really happens is that for anything to happen, they would always want to ask for funds. But there are those low hanging fruits or solutions that we can actually implement. So we taught the program managers and healthcare workers, or we put them through all these various steps, on how they can use data at each step in time to come up with the strategies to improve coverage and service delivery.
Thank you so much, Chisholm, for that really comprehensive answer. I think it might be good to go to a separate but quite related question for Dr. Ismail that we've got on file, which is, what strategies are in place, Dr. Ismail, to improve data quality and the culture of evidence-based decision-making amongst healthcare workers in Lagos State?
Having me here. Thank you very much. Having listened to the previous discussions and the speakers, the strategies that are available in Lagos State, especially for the use of data for informed decision, where depends on the different departments that we have, and then the different programs. If we look at disease surveillance system, that is very important in detecting disease outbreak and monitoring public health event. We have the integrated disease surveillance and response strategy, and that strategy is something that started from different levels. We have those that we start from the community level in terms of getting data, informing the health facility surveillance focal person. The health facility surveillance focal person will get this information to the district or the local government surveillance officers. From there to the federal level is a particular feedback mechanisms. Now, this feedback mechanism goes back to the users, starting from those that collect the data, those that are going to use it for policy and decision making. So that strategy is one of the most important strategy that we have in collecting data for programs. Then going to another program like the maternal perinatal death surveillance and response. This information is at the level of the health facilities. We have the different health facility carrying out the a kind of a feedback mechanism on monthly basis. And since these are started with scorecard and also award given to facilities that have the lowest maternal deaths, the lowest perinatal death on annual basis. We have had improvement in our maternal mortality and perinatal mortality. Thirdly, the other strategies that are used in using data for informed decision is research. And this we actually use very well during the COVID-19 response. The outcome of research was very, very important in formulating policy. Most importantly, is the home-based care, home-based care strategy that was adopted in the country. And this started from Lagos State, because research was conducted and we found out that you cannot admit all patients into the facility, because the patients that are asymptomatic are actually, wasting the resources. They are doing nothing there, and we're having less spaces available for admission. And at the end of the day, we started the home-based care, strategy, which was based on data, on evidence, that we saw from the outcome of those researches. I think for now, let me stop here. Thank you very much.
That was a very comprehensive answer, Dr. Ishmael, so thank you so much. I can see Dr. Chisabut is being incredibly active and helpful in answering some of the questions in the chat, but I wondered if perhaps Eduardo, you'd like to come in on one of them, because I think it's a quite wide-ranging question that it would be great to hear lots of perspectives on. And the question is, how effectively can we ascertain the genuineness or the kind of accuracy of data that's collected in the field? What are the key methods of ensuring data accuracy?
Okay, thank you very much for that question. And actually, I would like to come back to what Professor Chisova was saying at the beginning, how different data sources is giving different results, right, for coverage of routine immunization. What we are doing from UNICEF side, we're working in different levels. One, of course, is to strengthen the capacities for DHIS2, right? To be in order to have health officers that are able to introduce the data, not only that, but to use that. One example as well, Chisova mentioned that, is the scorecards, that every state is updating them. The 36 states are updating them in quarterly basis. Last quarter, 32 of them updated them, so it's quite good. And normally after a reminder, all of them are updating them, and then use the data for decision making. So for us, this work on DHIS2 and not only ensuring that we have the data, but as well that this is used for decisions, this is very important. I would like to highlight as well something that for us is very important and is regarding the visibility of vaccines. So one of the big issues that we have been having is we know that the number of vaccines that they are coming to the country, but then we don't know how they are used, right? We as UNICEF, we are importing 400 million doses of vaccines per year. That's massive. But at some moment, after a central level, we lose visibility on what they are going. So what we did, and we're working a lot on that with some other partners like Gavi and others. So the first one is we did a national inventory of vaccines, right? So at some moment, like in any store, you need to take a stock where we are. So last quarter of 2022, last year, we did a full inventory of all the vaccines at country level. Now this quarter, we are doing as well a cold chain assessment at country level. So where are the vaccines and where are the fridges where they are stored? So what capacity they are they functioning, are they not functioning, are decommissioned, etc. The second one is to increase the visibility. How we have been operating as business as usual over the last few years. That in UNICEF, we have at least one person by state reporting on the stocks of vaccines that they have on a monthly basis. This is, we're in 2023, right? And in Nigeria, so we can do better than that. So what we have been doing is supporting the expansion of the ELMIS, so Electronic Logistics Management Information System, as well with some partners. And at this moment, we have weekly live data on the number of vaccines that we have at LGA level. And the last week I checked, we had over 80% of weekly data from 80% of the LGAs in the country. So it will be 680 or something like that. So if you don't invest, you're not going to move from the crab in, crab out, right? So you're always going to have that. So really, it requires a lot of investments, a lot of follow-up, to be working as well, not only with central level, that's very important to us, not only with the Federal Ministry of Health and NPHCDA, but as well with a state level, to ensure that we have a good data quality. So there's still a lot to do. I think the next step, as I said, is how we use the data, right? If now we are able to know in weekly basis if we have stockouts or we are at risk of stockout, how we use that to inform decisions in terms of importing vaccines, in terms of redistributing vaccines, etc. And again, we have a very good example during COVID-19 times. We were able to do that for COVID-19, even with less data. Like almost on a daily basis, we were monitoring where the vaccines were, how many people were vaccinated and when, the expiry dates of the vaccines. So we should be able to do that moving ahead. So yes, we have good practices, but it's still a long way to go. Thank you, Izzy.
Oh, perfect. I'm hopefully sounding loud and clear to everyone again. Thank you so much for that answer, Eduardo. I think I'd like to roll on now and look a little bit about some of the issues around the challenges collecting data, specifically in hard to reach areas. This was a question that was put in the chat. Dr. Chisborough, I see you've provided an answer. It would be great if you could also provide that orally. And then if any other panelists want to come in on it, that would be great as well. I'll repeat the question quickly for everyone's benefit. The question is, how is data collected in remote and hard to reach areas in Nigeria? What are the current challenges? And are there any particular actions that are being taken to improve this process at the moment?
Okay, thank you very much for that question. I think there wasn't the questioner or the commentator did not specify what data they are talking about. So I'm going to talk about the different data sources. So starting with routine data. So if it's data that is collected in the health facilities when kids come and they are vaccinated and the vaccinator, the health worker is reporting routinely, regardless of whether it's in a remote area or an accessible area, every health facility in Nigeria that is providing immunization services is equipped with the tally sheets and the registries. So there are data tools in every facility that enable the health worker to record the vaccination services that they are providing and then report that up. So the way they report it up is it's still paper-based right now. So they use the monthly reporting sheets, they fill it out, and then they send it to the local government area, the LGA, and then the data is aggregated upwards. There is also what I mentioned earlier, SMS data reporting. So where from the facility level, the vaccinators and the facility managers are reporting the data that the services they are providing by texting the number of vaccines they've given to a server, and that is collected. So whether it's in a remote area, if they have network service, they can actually text that information from their health facility. But if they don't have network in the where their health facility is, because it's very remote, sometimes what the vaccinators do or what the providers do is they go out when they go to the LGA headquarters or when they go to a different town where there's network, they can now send their SMS reports. So that's how they do it from the facility in places where they don't have network. When it comes to survey, it depends on which enumeration area has been selected from the survey design. It's expected that those enumerators or data collectors who are assigned to any community, whether it's a remote community or an inaccessible community, is expected that they should go there and collect the data. Now, and to do that, you would obviously have supervisors, right, that will monitor the activities of these data collectors. Another thing that has been done by MPHCDA and other partners is to have the data collectors or the vaccinators geotagged. So they have tablets that can show their location. And so using GPS technology, they can actually see where the data collectors are going or where the vaccinators are going. And if from the visualization of the movement, you can tell if data collectors are going where they're supposed to do. So there are a number of ways to ensure, first of all, that the data collection is happening, that the data collectors are going where they ought to go. And then for the quality, there are quality improvement and assurance processes that can be put in place. But the most important thing I would say is ensuring that there is good capacity, that there is training and there's capacity for the data collection so they know what to do and how to use the available tools.
Thank you very much, Dr. Chizoba. And I think that links really nicely to my next set of questions, which are going to be focused more around interventions and thinking about specific tactics and strategies that can be employed to improve that training and capacity building element. And I want to give my first question on this topic to Jadida, who I know is part of Vaccine Data Collab, helping to facilitate 7 grants to grantees who are running interventions aimed at using localized data to improve vaccine coverage and service delivery. So I wondered, Jadida, if you can share any initial insights from any of these interventions. What are they focused on? What approaches are they employing? And what are we learning about what's been effective?
Thank you, Izzy. Yeah, so we are supporting 3 interventions in Nigeria. And these interventions are around data governance and data sharing policy. We also have data for decision-making tools, and we have capacity development. So in terms of the reason why we are supporting 3 portfolios instead of just 1, because we need a combination of solutions in order to unlock the power of data. Because there has been so many shiny tools out there. And we also know that to solve the issue of data, it's not just one thing. You have to look at the complex part of it and to bring all the intervention together to be able to solve that. And so what has been proven to be effective, one thing is some of the workshop that we did initially before we went live with the project. So the workshop was done in January, and it has proven to be effective in terms of identify and also changing the behavior and also identifying the data issues. And this form part of the project, looking at what the Nigeria people feel is the problem with the data that they have. So this was not something that the Vaccine Data Collab sat down and decided, this is what we are going to be doing. But this was from the people of Nigeria, and also making sure that the solution is something that the people of Nigeria wanted. Another thing was the stakeholder engagements that some of the intervention the grantees have been having have been proving to be effective, because some of the dashboards that are coming out, or some of these tools that are coming out, is not something that it's them to decide. So they have been having a stakeholder engagements to have the user requirement from the state, and not something that they also just come up with. And also to just make sure that some of the indicators in those dashboards is something that has been used by the state. So what some of the drivers for the success of the intervention we have in Nigeria so far is as a Vaccine Data Collab, and together with our grantees, we have actually embraced innovative technologies. So one of them being the tools that we are also using is like machine learning models. So this machine learning is being able to automate and also to help the government to know where there are the gaps and what can be done, and especially looking at the zero-dose children and also the missed communities, and also utilizing the geospatial technology and also to be able to triangulate some of this data. So it's more of working from what is known, working from known to what is not known. And also another part is the capacity building. So just being able to empower the health workers with data skills and knowledge, this is ability to make sure that they have the ability to make evidence-based decision moving forward is something that also have proven to be also a success. Another part is the data integration and standardization. So one of the tools that is coming out, that's going to be coming out by the end of the project, is going to be able to bring data from different, so extract data from different platforms into one stop shop that you can be able to get all your data. So for example, if instead of just going to SOMAS to get certain data and DHIS tool to get another data, this tool has all the data together. So it's actually going to be able to improve the accessibility of data and also improving the quality of data, because the data is coming from one source, and also just making sure there's a standardization of this data when they come together, and also making sure that the platform or the tool is also open to people who want to do research in that area of health, and also the policymakers, because another thing that we have seen or within this project is the tools that are there, they're closed. So you need some access levels. And again, the health workers cannot access certain data, which again might not make sense, because what if that data was very vital for their decision? So to talk some of the challenges the project have experienced so far is when it comes to data access and to being able to create the dashboards some of the interventions are looking at, the process and the bureaucracy at the state level have proven to be a challenge, a major challenge. And also this is going to form part of making sure moving forward, part of the recommendation for the intervention, especially on the data sharing policy, because what we have noticed or realized is there are no specific policies when it comes to data sharing at the state level, and what are the protocols when you are supposed to extract data for a certain platform that also is under the government. So that has really proven to be a challenge. And also the complexity of the building resilient health system. So they happen to get the data at the local, the national level has also not been so much good in terms of when you get this data, there's no standardization of the format of the data that you get. And when that happens, then it becomes a challenge from the end user to integrate this data together. If you are a health worker and you are supposed to get data from DHI, get data from SOMAS or any other platform that exists, when the data is not in a standard format, then it brings the issue of data quality. Yeah, thank you, Izzy.
Thank you, Jadida, for that really comprehensive answer. I feel like that's touched on lots of different bases that we could go to explore, but I saw you nodding along, Chisholm, and one of the questions that I had for you actually was about tools and technologies that are being used both in your work and kind of your wider knowledge of this space to help address some of these barriers. So I don't know if you want to come in on any of Jadida's comments around the need for more accessible data tools, which is certainly a need that we've seen in our work as well.
Yes, thank you, Izzy. Yes, certainly I was nodding while Jedi was speaking, because that's one of the challenges that we're seeing as well, right? First and first is the data availability, right? The quality is one area, but the data availability is not accessible to a lot of people, even those that is in the program area, talking much of those at the lower level. So in the course of Dr. Wonder's presentation, she also did highlight some of the things that the government is doing in terms of, making sure that there's real-time data available. So the SMS reporting and all of that. But then there are still some challenges with those SMS reporting when they are coming in, right? So till date, at the health facility level, data is still being collected via paper, it's still paper-based. So it's high time we start thinking about how can we come up with a mobile application where we can collect this data real time in terms of at the point of entry, so that we can minimize some of these data accuracy issues, as well as improve data availability. I do agree with Jedida's point about having that secured and standardized data sharing platform. So that way, we can also improve collaboration in terms of making those data available for people to use for action. One other thing I want to really mention, which was a kind of a very big challenge we found when we did our training needs assessment, was the lack of skills of these healthcare workers to actually, interpret this data. Which is why I'm wondering, or I would advocate for the need for us to have like a very a user-friendly data interpretation tool or analytical tool that can actually help these program managers analyze and interpret this data. So for example, during our training needs assessments, one of the key findings there was that majority of these healthcare workers cannot interpret the monitoring charts. So this is a chart that is clearly on their wall. If you go into the health facility, those charts are there. They input the data there, but they cannot interpret the data. So also many program managers also find it very difficult to even interpret the data that is coming from the various levels. So if we can have a tool that can analyze this data for them, as well as interpret it, it will make it really easy for them to use those data for action. So we have the DHIS tool that is widely being used. It's not accessible. You just have to register or have access to that platform. Now, can we have like a guest feature on that platform where people can actually, or even they say a request feature on that platform where people can actually request for that data? Now, on the same platform, can we have like a learning prompt where if these program managers pull up the data they want, the prompts can easily analyze the data for them to tell them, oh, this is what this. So that way, people have access to this data and use it for action.
Thank you so much, Chisholm. And I think that's clearly resonated with a few people in the audience, because we've had some comments talking specifically about certain indicators that are a bit of a challenge that this commenter is speculating in the data chain, and the comments around the need for a quarterly microplan update and preferably an annual walkthrough of microplanning, which I know has been one of the key focuses of the work, getting people familiarized with these microplanning frameworks and equipping people with the skills to be able to use them. On a related note, again, around data tools, we've had a question for Eduardo. You mentioned geotagging, Eduardo. How is this being utilized, and which immunization services are they being used for presently? And kind of related to this question, how are broader digital approaches being streamlined to ease the process for immunization officers? So the question really focusing on geotagging and other digital approaches that can be used to help address some of these obstacles.
Excellent. Thank you very much, Izzy, for that question. I mean, geotagging is used especially during campaigns, right? So, for example, in the polio campaigns, the polio variant campaigns that they are happening, is routinely used to track the different teams. This is something that is done, and let's say routine basis as well, has been used in COVID-19 for the COVID-19 teams, not in all the states, but in many states. I think that's the way forward. We need to, so vaccination campaigns, they require a huge effort in terms of human resources, but as well technical resources and financial resources, right? We are moving, especially for the outreach post, we are moving like maybe hundreds, thousands of teams during few weeks to really make an impact. I mean, just remember like last year in the integrated campaigns, more than 40 million children were vaccinated. So we need this geo-tracking. This is happening, this has happened, maybe sometimes inconsistently. But as I was saying earlier, it's not only about having the geo-tracking, but as well how we use that to inform and to supervise, right? Because the risk is that you get a lot of information, but you're unable to really use it. Even this morning, I had a conversation with some colleagues, and because there are some initiatives on using AI to try to verify actually the data, right? So, okay, this data is coming to us, so how we can use like bulk data and AI to analyze the data. But I would like to highlight that, to me, the biggest step forward that we need to take a decision as a country is digitalized immunization. I was a couple of months ago, I was visiting a couple of PHCs in Lagos, and they're already using digital tools, for example, for the health insurance, but however, not for immunization, right? When we know that actually is the public health intervention that saves more lives. And it's not only for immunization. To me, if we start even earlier, what we are seeing that the rights of a child start with birth registration. So if we are able to link birth registration, right, having a NIN, having an ID, having that this baby is registered, exists, is counted, then with immunization, that will be the great leap forward. And this is especially important because of the huge number of zero-dose children. We have, so something as well that we have been doing with partners is to identify the what we call the 100 LGAs. We have been able to identify with as well the geo-tracking the 100 LGAs in the country with more children zero-dose children for, I mean, for the public is children non-immunized, but for us, we are technical people here, it's children that they didn't receive Penta 1, right? So we know that the country at this moment has 2.2 million children of the cohort 1 year to 2 years that has not been immunized against Penta 1. We know that many of them, so a big percentage, is in this 100 LGA. So what the vision that we have is like, if we need to move strongly to link their birth registration with the tracking of immunization, and to ensure that the teams that are going to vaccinate them have your tracking devices, so we can use that and we can supervise and assess using AI, because we are talking about huge numbers. I don't know if this is a dream, if this is feasible, but we believe it's everything about having the vision. So we are working very closely, mobilizing the funding as well with technical partners, and I hope as well with some of the academia and researchers that are here in the room to really move in that direction. I hope, Izzy, I responded to your question. Thank you.
You did indeed. Thank you, Eduardo. And I actually want to ask a linked question because it relates to your reference to AI and machine learning, which was posted in the chat a little bit earlier, which was Maureen from the Federal Ministry of Agriculture has contributed that she believes that social listening could be very effective in helping driving data-driven decision-making. What are people's perception about a certain vaccine, and to help inform, our understanding of people's perceptions around what vaccines are the biggest cause of concern, understand general attitudes and potential demand issues. So I guess this can be an open question to any of the panelists. Is anyone using social listening tools as part of their current data-driven vaccine projects? And do you want to speak a little bit about that? Maybe just raise your hand and then I can come to you one by one. Go ahead.
I don't know if Chisom was before me, so maybe Chisom, you want to go first, and then I will.
Okay. I just want. Okay, thank you so much. So I just wanted to say so for our project, we're not using social listening per se, But what we're doing is, so the human-centered design sessions that the trained healthcare workers are doing with the community. In fact, we had our first session last week. So it's also some sort of social listening approach, because with that, we are using, like I mentioned before, we're using the BESD tool, that's the Behavioral and Social Drivers tool, that's had specific questions to really understand, what they feel about vaccine, about the various vaccines, be it a routine immunization, be it the COVID vaccine. What are their concerns about the vaccines, right? What are the things around them that can inhibit or drive them to vaccination? So what motivates them? So it also, in quotes, can be a social listening process. And one of the things we're encouraging healthcare workers to do is to do that all the time. So we're having sessions, encouraging healthcare workers to have those sessions with communities guided by those tools, so that they're able to identify which of these, along these domains, which one is really driving or inhibiting vaccine uptake. Thank you.
Thank you so much, Chisholm. And I think, Eduardo, you wanted to go, but Dr. Chizoba's also got a hand up. So maybe we go to Dr. Chizoba and then finish with Eduardo.
Eduardo had his hand first, so he can go.
Okay, thank you. Mine is very brief because I'm not really an expert in social listening, but yes, we have been doing that, and we're doing it for somehow vertically. We are doing it for polio, and as well we are doing it. We have been doing it for COVID-19. During the COVID-19 pandemic was really useful to do that. So we have been doing social listening as well, rumor tracking, etc. And this has been strategies that they have shown to be very, very effective, especially for the to ending polio and doing the COVID-19 response. I don't have really the details because this is outside of my area of expertise, but just to highlight that, yes, we do it.
Yeah, okay, so from previous projects and from current projects, you could do social listening online, to listen to the chatter on Twitter, on Facebook, using keywords to see what is trending. And we did that for one of our projects where we were involving civil society organizations and engaging them for COVID-19 vaccine response. So social listening can be done online. There can also be social listening that's done in person. So one of our projects right now is to activate civil society organizations for the HPV vaccine introduction, as well as activate communities. And we're changing the language of community engagement to, typically when you hear community engagement, or when you hear, let's say, health workers talk about community engagement, they talk about it in terms of, we are going to the communities and we're going to talk to them about immunization. We're going to educate them about immunization. But we're changing the language to be more of a dialogue, a back and forth. So listening to them and responding to them, hearing what their challenges are, what their concerns are, the myths and whatever is circulating. So once you switch the paradigm from going to talk to healthcare workers and having a dialogue with them, you are going to be doing social listening. So it's not this fantastic new thing that comes from somewhere, but it's something we can do once we change our mindsets about how we engage with communities. But another thing I wanted to point out is that not everybody considers that term social listening as a neutral term. I remember there was a write-up we did where we included social listening as one of the activities, and the recipient came back and said, "What is this social listening? It's sounding like surveillance. It's sounding like unauthorized surveillance." So we have to also be careful about the language that we use for different things like this. So that's the point I wanted to put across. Thank you.
Thank you, all three of you, for those really insightful contributions. And I totally agree, Dr. Chisborough. It's definitely something we, as an organisation that does a lot of monitoring and mapping, you have to be really careful to ensure that that is done in a way that feels engaging and collaborative rather than surveillance. It's definitely not a word that we'd want associated with our research. So one potential obstacle to be aware of when you're trying to get people's buy-in for these tools. I think we've only got time for about one more question, which I'd love to direct towards you, Dr. Ishmael. It's a question from the chat, and I think you'd be well suited to come in on it due to your role in Lagos State. The question is, what is being done in terms of capacity building of cold chain officers at the LGA level to accurately forecast vaccine and conduct vaccine quantifications to prevent frequent stockouts? So I think this is really a question around supply chain sustainability and how the state is approaching that. So if you could come in on that, that would be fantastic.
At the level of the state, a lot of training and retraining of cold chain officer and the immunization officer. And most of these training are supported by partners, and it has really improved the data reporting and the quality of data that we get from these officers. Secondly, there are regular data validation activities that are going on, especially at each LGA on monthly basis. The medical officer of health with the other health team within the LGA, they present data, they report data from the different facilities, and they harmonize their data. And this also is something that at the medical officer of health meeting with the permanent secretaries, they also make presentation, look at this data. Then WHO also in area of immunization and give a lot of support to the cold chain officer, to the local immunization officer. And this has been, that this has increased or has improved the level of data that we have from these particular officers. At the level of the state as well, I also wanted to contribute because you're talking of access to data by health workers, the different platforms that are used. Well, in Lagos State, we have what we call the State Health Information Platform. And what we're trying to do is to ensure that the different dashboard, because you have different dashboards created for different programs. You have those for disease surveillance, you have the one for adverse event following immunization, you have those for facility reporting. But again, we are trying to have harmonization of the data and a platform that accommodates all these different data, platform, so that those who are who are heads of organization, like the permanent secretary, like the commissioners, at a glance, sitting in their office, they can, be able to visualize what is going on in different aspects of the health systems. Aside the facilities, what is going on at the level of surveillance, what is going on in health, health insurance. I think one of the panelists was talking about the digitalization, in terms of data collection at, of insurance. And these are things that I feel that we need to do. Again, in terms of access to data, I think it's very important for us to also look at the aspect of data protection. A lot of people wants to get access to data, but this needs to be regulated. In Nigeria, for example, now we know we have the Nigeria Data Protection Agency that is, looking at, how you have access to data, what you use the data for. You need to get permission. Ethics is also very important in this aspect. so that it's not just anyone that comes and have access to data. It must be regulated. It must be seriously monitored so that we don't have data being used for other things by other people who are not going to use it for the benefit of the system. Thank you very much.
Thank you, Dr. Ishmael. And what a great note to end on, a note that chimes with all of our other panelists' answers. I think the one thing they've had in common is how detail-orientated they've been. And I know that that's quite tricky to do on a topic like this, which is in itself quite a complicated one. So thank you all for your participation and your great answers. I'm going to move over to Dr. Fajero now to give some closing remarks before we wrap up the session. But just before I do, a final reminder about that survey. It's going to pop up on your screens at the end. If you could just stay for a minute longer to review it and fill out those answers for us, that would be fantastic. Over to you, Dr. Fajero.
Thank you so much, Izzy, for this wonderful panel session and webinar as a whole today. Thank you very much for moderating us. And just to say that today has been truly, truly insightful. Data for performance management and improvement of immunization is really key to all that we want to do in the vaccination space in Nigeria. Particularly, I'm excited at the strides that we have gained as a country. As you can see from Dr. Wonode's presentation, we're not where we were about 10 years ago. So while we are always focused on gaps with public health, we can also celebrate wins in public health. And some of the wins are that we have data tools in all facilities at all LGAs in Nigeria. And another win is that we have vaccines, accessible vaccines, and thanks to UNICEF Gavi for the work they've done in making vaccines accessible in Nigeria. So we have vaccines in the country, we have data tools. We also have the EMID platform now that was used in COVID that is going to be spread now to ROI. And you know, Eduardo was speaking about digitalizing the data tool. I think the EMID platform it's hopefully when we extend that to RI, which is already being done by the National Primary Healthcare Development Agency, we would see that sort of digital AI being used to track every child that's born, and hopefully will reduce that statistics of 2.2 million Nigerians with 0 dose. And hopefully, yet we also, again, cannot complete this webinar without highlighting some of the areas where we are advocating for and where we are asking both the government and every public health professional on the field, making sure that vaccines are utilized and are taken up by children, is that we've spoken about a lot about the standardization of data tools, the digitalization of data tools, the synchronization of the tool, so that we have every indicator we need in a particular place, also access to these tools. And I'm very particular about access to data from immunization data. And I'm hoping that we're advocating to the government on how we can make sure that the indicators and the data is accessible to both program officers as well as the public. The public needs to know how their state, how their the state government is performing as regards immunization. Another thing that has been highlighted very strongly is capacity building. Because these tools are ever evolving and ever changing, we're always having to train and retrain healthcare workers, frontline workers that take this data. So capacity building, very strongly advocated for. We need to keep training on data utilization and data tool, and exactly data also interpretation for decision making, very, very important. And AI can help us a lot in that. And hopefully some of the outcomes of the EMID would be that we have some AI that can interpret data for utilization. And I think that someone also mentioned micro planning. which is really important, because if we don't understand how to what the denominator is, then we probably cannot even analyze the data. So thank you again to our wonderful speakers and panelists. Dr. Wunde, thank you so much for that very rich presentation. We know that this is the beginning of collaboration for us and for you and NSSF. Thank you, Eduardo Blanco, for coming here and encouraging us and also speaking to your experience on the field. Thank you, Dr. Adeshina Abdul Salam. Thank you for the work you're doing with Lagos State and agreeing to come on this webinar to share the great work you have done. Thank you, Jedida, for Vaccine Collab. Thank you for coming and joining us on this webinar today. Thank you, Chisom. Thank you, Chisom Obijef. Thank you so much for joining us today. Very insightful conversations we've had. And of course, thank you to all our participants for joining. We're doing fantastic work. We encourage you to keep pushing and keep pushing. The needle will eventually move someday. And when we gather again, sometime we will see that we've done remarkable work, especially with data and utilization for immunization. Thank you, everyone. And thank you, Izzy, for a fantastic presentation or facilitation. On behalf of NSSF, Nigeria Solidarity Support Fund, and all the wonderful staff that are working behind the scene, we thank you for joining us today. And we say just take the poll. I think the poll should come up now. If you can take 1 more minute to take the poll at the end of this webinar, we would like to get feedback from you. We can't be speaking about data and not using data to assess the performance of this webinar. So encourage us by taking this poll. It shouldn't last you more than 60 seconds. And thank you very much.